of the talk. Thanks, Wasim. Quick agenda of the talk. We're going to start off with phase one, pretty much where we've been, what we've done, before transitioning to phase two, which is more of, where we're going with this work. So I'll start very quickly with just a bit of background. Um, Currently, there are almost 2 billion children on the planet who lack access to surgical care. And a significant proportion of these children reside in low and middle income countries or LMICs. This is particularly acute in Africa, where the population is comprised of approximately 50% children. This translates into a high surgical disease burden. Our working definition for the social determinant of health, gender, is taken from the WHO, characteristics, roles, and behaviors attributed to what is deemed masculine and what is deemed feminine. Historically, gender has played an important part in hierarchical power imbalances, whereby females have been deemed inferior. In fact, in certain instances, gender inequity has given rise to social and structural barriers negatively impacting females. And this appears to be reflected in recent reports out of the continent that suggest in certain communities, women are less likely to seek care for their surgical conditions, and those who do tend to have worse outcomes. So, a gap has already been identified in the adult population. However, the potential for this involving Africa's children has yet to be clearly elucidated. So this has all given rise to my research question. Are there gender disparities in pediatric surgical access and outcomes in Africa? To answer the question, we conducted a systematic review followed by a random effects meta-analysis. My caveat at this point that I usually make a point of mentioning is that since most global registries and studies still characterize their cohorts according to sex as opposed to gender, we use sex as a proxy for gender in this work, particularly as we were looking at conditions that were sex neutral in nature, or that didn't differ in prevalence or severity in boys as opposed to girls. And we verified this methodology with a number of sex and gender research experts, EDI advisors, and of course, our African counterparts. So what did we find? Out of initially over 12,000 records retrieved, this was whittled down to a finalized list of 54 studies. The majority were retrospective, single site in nature, stemming from Egypt, Nigeria, Ghana, or Ethiopia, published in 2010 or more recently, with study durations of 5 years or fewer, cohorts of 200 children or fewer, and they focus primarily on pediatric GI conditions, some of which I've listed here on this slide. Our meta-analysis yielded odds ratios that suggested surgery was performed almost 4 times more often on boys than girls, while mortality was almost 2 times higher for girls as opposed to boys, and that's for sex-neutral conditions. So we're embarking on phase two of this work, which will involve taking a deeper dive into this issue. And that will be via a mixed methods, multinational on-site approach. And of course, this work is going to hinge upon strong collaborations with our African partners, ranging from community leaders to caregivers, even current and former patients themselves. The work will take place in a number of sites across the continent, Nigeria, South Africa, Tanzania, and Egypt. We are hugely fortunate to have amazing site leads at each of these locations who will basically oversee local the logistics and basically oversee the work at their locations. They will definitely imbue this work with a much needed cultural safety and guidance, and also they will recruit key facilitators who will assist us in this work. For their part, the facilitators will in turn recruit participants collect data, assist us with translations, and even data interpretation, all the while strengthening their own research skills and building local capacity. Since this work will highlight the voices of children and their families, they will be recruited very early in the process and liaise with us as knowledge users and experts in light of their lived experiences. And overseeing all of this, is our research advisory team, which spans a number of different continents, spanning, with a wide array of expertise, ranging from, general surgery to pediatric surgery, pediatrics, biostats, epidemiology, and so on. This slide is a rough schematic of the methodology that we will apply in this work. It consists of 3 stages. The first of which involves identifying participants' priorities, their perspectives, their customs, and their traditions regarding this issue via community-based participatory focus groups. Open discourse, is essential to center perspectives that may have historically been misrepresented or mistaken or marginalized or, excluded altogether. The discourse will also be encouraged via stratification of the focus groups by age group, gender, and also role. And some of the ideas that come out of this first stage will inform some of the questions that we'll ask in stage number 3. So in stage 2, we'll explore child experiences by gender via caregiver surveys, informed by the 3 delays of care model. This will also be accompanied by a great qualitative tool known as active sense making in order to, root out or get at more of the nuances of perspectives regarding gender. Active sense making involves micro-narratives or short stories elicited from participants to reflect their experiences. This is a validated tool that has been used widely in a number of different settings, but also in Africa in particular. And what's really important to emphasize at this point is that, at no time during the stage will we be talking about gender disparity or gender inequality or anything like that with respondents through this tool. And that will help, encourage spontaneous storytelling and reduce the potential for response bias. Whenever possible, we're going to utilize the tool of body mapping with children who are, given permission by their caregivers. And that basically involves visual representation of their thoughts and feelings and their experiences onto paper cutouts of their bodies to promote self-reflection and empowerment. And this also is a validated tool that has been used with African children and other groups and has been deemed a sensitive and respectful means for collecting data, discussing complex or taboo topics, and overcoming potential barriers of, language or culture, and also promote awareness. Lastly, any of the participants who, are amenable from stages 1 or 2, and also new recruits will participate in stage number 3, which will consist of focus groups, where participants will be asked open-ended questions about barriers to the surgical care of children in their local context and practical, achievable solutions to address these barriers. throughout this entire throughout all of this process, with all of these various tools, they will be they are not will be they are trauma informed, so as to avoid exacerbating respondents' pain and any pathologizing of their communities. We will be recording responses throughout the process through all three of the phases. Um, they will be translated as needed, transcribed with the help of our facilitators, and then coded for thematic analysis. So in terms of our endpoints, we're looking at surgical access and outcomes in order to better ascertain the barriers and potential solutions. Significance of this work is the following. We aim to capture, for the first time, much needed perspectives from children and their families regarding access to surgical care, outcomes, the drivers of disparities, and potential solutions. We will also highlight experiences and needs at a number of different levels, at the individual level, with the patients, the family, institutional, but also with the community. This work will raise awareness and also amplify homegrown sustainable solutions that will either directly apply to identify barriers or provide a blueprint or foundation upon which future interventions or initiatives can be built. Very quickly, I just want to mention some additional work that I'm involved in because there is, considerable downtime, in getting ethics approval, both locally and internationally. The first of which is a systematic review looking at gender disparities in ped surgical care in Canada as a comparative to the work done in phase 1. We're currently about a quarter way through that in the first pass phase. The second systematic review will involve, or does involve, gender indices. And through this process, we're really looking at, these composite variables that will reflect gender parity in a number of different environments, and really look at the history of these things, when they were established, who established them, what's their prevalence, how are they currently being used, in order to hopefully develop an algorithm that may assist others in figuring out which is most appropriate for their needs, and how exactly to use them. So we're about also 30% of the way through that systematic review during the first pass. Lastly, we're taking a dive into a fantastic database that has been graciously shared by one of our team members that involves work that she did as part of a multinational prospective cohort. She looked at over 70 countries, the congenital anomalies and conditions experienced, or that children presented with, looking at things like the demographics, the interventions that were applied to these children, and their outcomes all the way out to 30 days in a number of different settings, from high income to low income. So approximately 4,000 children were captured. And so we'll dive into this database, or we have started exploring this database to, see whether there are any interesting gender disparities in that as well. So I will stop here and open the floor for any questions.